Good morning, Dr. Mason.
Good morning, Cynthia. I'm Oren Mason. I'm a family physician originally, but for the last 20 plus years, I've specialized entirely in treating ADHD. I've diagnosed over 5,000 people with ADHD, many of them inattentive, of all ages. The youngest is 4 and the oldest is 82. Treating ADHD makes remarkable differences in people's lives. I practice in Grand Rapids, Michigan, and it's an entirely virtual practice. I spend my whole day on Zoom, like we are today.
What wonderful news to hear. People can access you if they live in Michigan.
There's people in the Upper Peninsula of Michigan who live a 15-hour drive from the lower part of the state. Access is truly important, and specialty services in ADHD especially are still really hard to find.
Even though we're going to talk about medication today, I wanted to start first with, once you've made the diagnosis, how do you share it with the family? I diagnosed it in a 7-year-old girl, which is our target population. And you're having the chance to sit with them and explain the diagnosis. What would you say?
This is a good place to begin. Our hope is that more and more young girls are brought in for diagnosis, and that's really your job. But assuming they come in and assuming they're diagnosed, I spent the biggest portion of an initial visit where the diagnosis has been made explaining what ADHD is. When you have the time and the visuals to do that, it's very apparent to most parents that their children do indeed have that. ADHD looks like a hyperactive first grade boy. ADHD has many appearances. There's both boys and girls who aren't hyperactive, but yet are struggling to pay attention, struggling with emotional reactivity, struggling with executive function impairments. Nobody comes into a practice like mine not wondering whether it's ADHD. I like to know what people's concept of ADHD is. I want to know what they think ADHD is.
So the child is in the conversation.
Absolutely. Most of the explanation is geared to the child, knowing that the adults will understand. If you talk about what it's like to have ADHD, even young children can go, yeah, that's what it's like. Do you ever find yourself looking out the window when you're not supposed to be and your thoughts go places that don't have anything to do with what's going on in the classroom, and then you miss something? Little kids can say, of course. You know what it's like to get so upset you don't know what to do? And most kids can say, sure. If you've asked enough questions that ring true, people are open to the notion that, yeah, there's an explanation for this. There's circuitry in the brain that doesn't work, and it works for other people. But when we try to do the same things that other people do, it doesn't go as well.
You got the electricity, but it's not plugged in.
Exactly. We talk about when you just have to do something and you don't want to do it, but you have to do it. We say the part of the brain that we use to do that is the Nike center. Nike center of the brain is the just do it place in the brain. Parents say that it's a useful way to talk about what we think of as willful cognitive function. The ability to decide to do something, not in the emotional brain, but in the cognitive brain, where time is important and where priority is important. Concepts that are beyond 7-year-olds, but that we're trying to teach them, things like prudence. It would be smarter to do it this way than that way. Experience teaches us that this is a good way to solve that math problem. So let's all practice solving it that way. People with ADHD have trouble connecting this would be smart, just do it, to behavior. A lot of young kids really understand, yeah, in your head what to do, but then you can't do it. You get distracted or you forget. If in the diagnostic process, you've asked a lot of questions that show understanding of inattention, then people are willing to say, yeah, attention's a problem for me.
They don't end up feeling that there's a defect in their brain, because that's what you hear so many people be upset about.
When you look at the number of connections that simply don't work in an ADHD brain, they just don't have enough neurotransmitter to function, it's jaw-dropping. There's hundreds that have been identified. Anytime we find a nervous connection in the body not working, it's really a big deal. I had one nervous connection in my body from my brain to my left leg that was crushed by a slipped disc I got a lot of attention for one nerve that was interrupted.
And you're saying in the ADHD brain, there's lots of.
There's hundreds of connections that are disrupted.
Ah,
If we're not clear that this is a big deal, this is a very big problem. To the best of our knowledge, it doesn't clear up. Inattention tends to get worse across the lifespan, not better. Hyperactivity tends to get a little better across the lifespan, but life gets harder. Inattention becomes more impactful as 7-year-olds progress through the decades.
I've never been bothered by thinking I have a brain that needs help, but a lot of people seem to be bothered by that. We don't get bothered that our eyes need glasses or that our ears need hearing aids. Why should we be bothered that our brain needs some help too?
I would consider your position enlightened. We're not experts at parenting. We need parenting coaches. Marriages are hard and that we need marriage therapists. Sprinting is hard and we might need a track coach if we want to be really good at it. Those are sensible thoughts for people who want to do well in life. There's fear of stigmatization and it's real. So I don't fault people for worrying that it might not play well in the public square because it often doesn't play well in the public square.
Yeah.
But I think just the opposite, Cynthia. If you think about how we think about disabilities in our culture, we've come a long way. One example of celebrating the efforts of people with disabilities is the Special Olympics. In the Special Olympics, we can see what difficulty they have. And we know that it's harder for them to participate in a 40-yard dash than for myself. So when they complete a 40-yard dash, we don't go, oh, that was slow.
Yes.
Stand up and cheer. And we give everybody a ribbon because when people do normal things, but it was harder, that's hero status. If we can be that way about physical disabilities, I think we should be the same way about intellectual disabilities. We should be the same way about cognitive disabilities.
Yes.
There's things that don't work.
Wow, it gets to be a real double-edged sword between us accepting ourselves and saying we have a defect or a disability, and people out there saying it's just a difference. But it's a mismatch. In sharing the diagnosis with the family, you're talking to the child, whatever age the child is, you're getting them to, in front of their parents, to acknowledge, yes, I feel this, yes, I am that way. And the parents hearing that helps to solidify that the child needs help.
Absolutely.
You said you had stuff that you showed them.
I show people pictures of others' brain scans. Just so that they can understand. They're just illustrations that come out of research studies, or there's groups of scientists that look for and map the connectivity in the brain. They publish visuals, which are called connectomes. And so you can literally see the circuits that are missing in ADHD brains. When the child says, yes, these are issues for me, and when the parents understand that it's largely inborn. ADHD has much more to do with genetics than it does with experience. When we explained that medications for ADHD act very differently in different people, and so there's not an algorithm for using those, but rather trial and error.
It's true with a lot of medications, and not just medication for ADHD.
Without question.
People bring that up as something to be scared about, that we have to have trials and to figure it out. But it's true with other illnesses too.
It is. There may be a false belief that's developed around medical treatments that the doctors know which treatments will work. In fact, what doctors know is which treatments have the highest probability of working. But there may be other considerations than just highest probability. But in a situation that does involve trial and error, we have to be very clear that there will probably be multiple trials. Secondly, we have to be clear that there may be errors. Doctors make errors. You can prescribe medications that have worked well for thousands of children, but in particular cases work terribly or cause side effects. Parents need to understand that difficulty in selecting medications for children with ADHD.
I don't want to have the listeners leave with the thought when you say you could make terrible mistakes. At least the medications with ADHD, because they're in and out of your body so quickly, the mistake is very short-lived.
These medications usually work. Sometimes they work fantastically. Sometimes they work well. Sometimes they work a little. All of it is to be determined. But if it's not going well, we have a phone number, we have nurses, we know how to stop a trial. We want our bad experiences to be very short, and we want our great experiences to be lifelong. That's what we have to manage in the medication process. We have to quickly weed out the poorest choices.
What we advise parents is to be doing all the things we know that are good practices for people with ADHD, even before they decide to go see the doctor. We think that helps them be ready to accept medication. They say we're already doing everything and it's not enough. When they get to you and you explain the diagnosis, are you ready then to put them on medication, or are you suggesting to them they do other things first?
There's times when we suggest people do other things first. Because I work as a consultant, I might see a patient who's had multiple treatment failures. So we might choose a non-medication option initially. But for the most part, because we don't have treatments besides medications with such response rates,
Yes.
why wouldn't we use the most effective treatment we have?
Yeah, that's what I say to parents when I see them time and money on unproven things. Why would you want to say, I don't want the most effective treatment? What we know to be the most effective treatment.
The only answer I can imagine is lingering unanswered fears. I understand the fears. I practiced medicine before we had any usable scientific information about what these were actually doing in the brain. I was afraid of them too. There were guesses, and a lot of the guesses were wrong.
The controlled substance part is where people get hung up.
Yep, although plenty of people are hesitant about non-stimulants too, which aren't
Yes.
controlled. If things have known side effects, caution is called for. One of the biggest reasons not to go trying barely tested things that they're not well tested, we don't know what all the side effects are. And that doesn't mean that they're side effect free. So that's a dangerous avenue too. It shouldn't be considered a safe alternative. It's arguably more dangerous because you're going down a hiking trail and there's no map.
That's a good argument. Uh-huh. When you are going to recommend medication for a young girl, how does that look?
First off, we explain what the purpose of the medication is. Since the basic problem, as far as we know, is there's connections that aren't happening, we want to raise the neurotransmitter level, which should improve the connections. You should be able to do things on medication that you can't do without the medication. We'll have very specific targets.
Specific behaviors you're going to watch for to see if they
Exactly.
improve.
We need to define the targets. And that's one thing that ADHD is rich in behavioral targets.
There's so many areas you could choose, the most troublesome, and see if you can improve that.
In lab classrooms, there's a very sensitive measure of medication effectiveness, timed math tests. The ability to attempt more and to get proportionally more correct in a timed math test is a very sensitive test of attention. That's a way of measuring improvements in attention.
Any parent could do that. Get a sheet of rhythmic problems that are on the level that the child knows, have them do it twice.
You can ask ChatGPT for 20 pages of math problems, all of a similar difficulty, and be ready to test and retest at various intervals. If people aren't familiar with ChatGPT prompts, you say, my daughter is capable of two-column addition, such as 32 plus 69. Give me 20 pages with a 10 by 10 problem grid, 100 problems per page of a similar difficulty, but a random ordering.
So my knowledge of ADHD has come from a lot of people, but I have learned so much from Dr. Mason, and now I've learned about the easy way to test it. Earlier, I learned that teachers need to watch for the children with ADHD later in the school year, because children with ADHD look good at the start of the school year. They look good when something's new and different. And especially the inattentive type will show up more as the year progresses.
One of the most common markers of difficulty in children with ADHD is incomplete assignments.
We've already covered what parents can tell that the medicine is working. They should then notice the children functioning better in so many areas of their life just because they did so much better on this arithmetic test.
And
How
this
do
is
you
one
know
measure of many.
when you've optimized the medication?
We do something in my practice called measurement-based care. With the children in my practice, we ask the parents to fill out one of these with each visit. It's 36 questions, and scoring goes 0 to 108. The higher the score, the more ADHD symptoms the child will be dealing with on a daily basis. One of the things we look for, and this is a fairly standard measurement in clinical trials, we look for a 50% symptom score improvement. What we want to do is lower the burden of ADHD symptoms. And 50% is the benchmark. That's the minimum improvement we look for. We'll take 90, we'll take 99. But 50% is considered a benchmark of good treatment.
If you've tried many medicines and you're getting 0 improvement, and then you find one that gives you 50% improvement, you might stop at that point.
Absolutely. With children, and especially with inattentive children, I'm more likely than the average doctor to begin with non-stimulants. Non-stimulants work more slowly,
Right.
but the improvement curve on non-stimulants often continues for many months after the treatments are initiated. Stimulants will only have a 20 or 30% improvement in the first month. That's not very good.
So as the physician, need to know the half-life of the medication to know how long to wait.
And the
You're gonna
expected
judge.
course of improvement.
What I've heard is you start with the stimulants and then go to the non-stimulants if you can rule the stimulants out. But it sounds like you sometimes start with a non-stimulant.
I do. Non-stimulants help in areas of executive function and emotional self-management and language processing, often better than the stimulants. And sometimes those are the biggest problems. Strattera and Qelbree may have some direct effects on anxiety, and a lot of our kids with inattention are anxious.
Yes.
We need to know where the impairments are coming from. And parents, if they know that emotional self-regulation may be better on a non-stimulant, sometimes would much prefer the one where it's more likely to affect emotional self-regulation. Now, understand that I'm making broad generalizations that just don't always bear out, and it remains trial and error.
Yeah, but I think the more knowledge the clinician has about medications and how they work and understanding the ADHD and what the needs are for that particular child, maybe you have a better starting point.
Exactly. And for example, if a child has dyslexia or other receptive language impairments, I'll almost always start with Strattera because there's several studies that show improvements in reading age on Strattera. But that doesn't mean
it's going to work.
It's going to work.
Yeah.
The rate of response, and especially kids who have pullouts for reading, who have a reading tutor, who are in Orton Gillingham programs, and somebody's measuring their reading age. Those kind of kids, there's measurables that will help us know how well Strattera is working. And so we can get information on how well it's working. Even if it's not a great drug for improving inattention, maybe it only improves inattention 30%. But if it improves all these other side issues, then we'll get into something that's even more complicated, which is combination therapy, and use a second very low dose stimulant to address the problems that the non-stimulant didn't. So you probably don't want to open that can of worms just yet.
I guess the message for parents is to try to find the practitioner who has the most experience treating children, because what I'm hearing from we know there's about 30 medications, and you need a practitioner that knows which one might be the best to start with, because you don't want to flounder for years trying to find the right medicine. So what do you have? What is in your toolkit when the parent said the meds work well in school, but she falls apart when she gets home?
And this is common. The stimulants by nature are very short-acting compounds. And so formulating them into something that matches the day has been difficult.
Yes.
And they're often different. The time release systems can work differently in different bodies, or even in the same body can work differently on different days. And there's some rules of thumb that I can give for using these, but in general, they last as long as they last. So if you're saying inattention is good through the school day and emotional self-regulation is good through the school day, but in the late afternoon, that really falls apart, then we haven't treated ADHD yet. When somebody has 24 hours a day of pain, we don't give them an 8-hour medicine and say, that's enough. Just enjoy the 8. So the impairments of ADHD extend into the sleeping. We know that people with ADHD sleep differently.
Yes.
And so we have to not only pay attention to sleep disruptions that we might cause with medications, but we have to pay attention to sleep improvements that we might see, because we have to count that in our assessment of how well a medication works or not. But in general, Concerta was a great drug for a lot of people because the branded form did a good job of lasting 10 to 12 hours. And for most school children, at least, that was sufficient. The generics aren't constructed very similarly to Concerta. And generic Concerta has been a disappointment. And I think over 80% of my patients who were on Concerta have now gone on to other medications because generic Concerta just wasn't a good match.
Concerta isn't made any longer?
It is, but it's expensive and it's excluded by a lot of insurance companies.
I see.
So it's difficult to obtain. Some insurance companies will accept a prior authorization if the duration of benefit, we say, of the generic isn't adequate. But many won't because of the expense. How do you get coverage for the medication that works for your child is a whole new issue.
The ADHD there is 24 hours, and so don't be content with the coverage for school alone.
Exactly.
Work with your practitioner to get coverage for much more of the day, because that is going to help your child too.
Exactly. And weekends too.
Yes.
The treatment of ADHD is 24/7.
Yes.
And children learn so much more outside of school than they do in the classroom. They learn how to be neighbors and friends, and they get their first lessons in parenting that they're going to need someday. They learn a lot more about safety outside of school than in. We treat weekends, we treat evenings, we try to treat it all. And
so say you've finally found a medicine that gives the 50%, but there are side effects. Do you stick with that medication and treat the side effects?
If we've already tried a half dozen and this is the best, we'll probably work with the side effects.
Yes.
People can't do trials forever and ever. And so there's many ways to work around side effects. A lot of people who are on a stimulant will have late day dysphoria, or as the blood level of the stimulant is declining, will have bad moods, grumpiness, mood irritability, trouble getting along, maybe anger, maybe anxiety. And so seeing emotional reactivity late in the day is common. And one treatment is to give a short-acting version of the same stimulant before the irritability begins. So if the irritability has an onset around 5 p.m. around supper time, for example, short-acting medication at 4 p.m. would be a common. So sometimes we'll combine that stimulant with a non-stimulant, and sometimes the non-stimulant will help carry a child through that emotional dysregulation.
What about the loss of appetite? That's what we hear about so much.
And the loss of appetite is much less of an issue if the medication is given every day.
Adapts to
The
it.
body adapts. And if you want the loss of appetite to continue, then give it intermittently. So daily administration is our best workaround for loss of appetite. And it's really rare that we need to do anything beyond that and just calorie adjustment, which is trying to encourage a really big breakfast and a really big, healthy supper.
This is for girls that start having menstruation. How does that impact with the medication? If they've been stable on a medication and then they start having menstruation, do you see that warrants a change at all, or how does that impact things?
Wait, no, that's a question that only recently we've been able to answer, but some very elegant studies were done on the interaction of hormones and stimulant uptake into the brain. And it turns out that fluctuations in estrogen matter a lot. During the period, every month, estrogen levels drop to their lowest level. And that's when stimulant medications have the least access into the brain. And so the amount of stimulant that crosses the blood-brain barrier into the brain during that 1 week is quite a bit less. We have to know when the onset of menses begins, not every young woman has noticeable differences during that week. But when they do, we need to increase the stimulant dose during that week. Non-stimulants less, but again, the drop in estrogen and the effects on attention are noticeable even in women who don't have ADHD. There is a decrease in attention during that week. And so depending on how great the variation, even some young women on non-stimulants will need a small stimulant boost just for that week, or in some cases, just an increase in the dose of their non-stimulant.
All right, that's something else I've learned from Dr. Mason. So finally, how do you address parents' fears that putting my child on medication is going to change them or make them different than who they are?
It's really important for parents to feel that the decision to try a medication is different than the decision to maintain a medication, and both are under their control. They can't know what a medication will do for their child in the best sense, or in even the worst sense, or in the sense of side effects. And so trials are really a precursor to making a decision for the long term. And if they understand that decision is in their hands, I think they're much more comfortable.
Yeah, to look at it as I'm not making a lifetime decision, I'm making a daily decision almost.
And then another thing that we're starting to get really good data on is the dangers of not medicating.
That's where 24 women wrote letters about their lives going undiagnosed and untreated. And we hope that ties into what you're saying, the harm of not medicating.
The harms of not medicating are great. And at the most basic level, the death rate is much higher for children and adults not medicated than children and adults medicated. In children and adults with ADHD, drops remarkably within the first 2 years of treatment. And so any concerns about safety of medication so far have been overwhelmed.
If you have the scale out there.
The concerns about not medicating are much higher rate of traffic accidents, much higher rate of drug abuse, drug dependence, much higher rates of accidental injury, of poisonings, of drownings, but higher rates of chronic diseases, poorer management of chronic diseases later in life, missed doctor's visits, missed medications. The list is just interminable. And just understanding that ADHD is in itself one of the largest risk factors that the individual in front of us is going to be facing helps get into perspective what the risks of the medication are.
One area our organization also believes in is that when anyone in the family gets diagnosed, everyone in the family should be screened. And parents are putting their children at risk if they have ADHD and they don't know it.
It's true. When I talk to primary care doctors, I think universal screening is most appropriate. I don't think we should wait to screen. The notion that we have a treatable disorder that takes lives really is all you need to know. The problems of the medications are real. They're not perfect. But the interventions that we already have pass every medical test for good treatment. The first-degree relatives, members of a household, have a 50% probability of having ADHD themselves. And so, of course, those individuals should be screened without question. If universal screening isn't practiced, family members should be screened.
Yeah, and for me, I've talked with women who say my brother got diagnosed, but no one considered me. And so I think that's another way to pick up siblings that have a different way of presenting their ADHD. So I just want to get that out there that families listening to this, they should not shy away from saying, let's us all get screened.
I think I couldn't support you more in that one.
Do you have any thoughts we didn't cover that you'd like to bring up?
Oh, dangerous question. I have to say we'll just leave it for the next time because there's always so much to say about ADHD. But thanks for the open forum. That's a fun invitation that I'm declining here.
Yeah, so when I started to just focus on this smaller group of young girls, I thought there's not that much to say, but the more you get into it, the more there is to say, the more there is to learn.
No, I appreciate your focus. It's been a group that was out of the spotlight for a long time. And I think your work is really important,
With you.
helping us find the hardest to find.
But I agree that we all should get screened by age 7 for ADHD. And that would be the direction I would encourage all physicians to work towards.
And then rescreen at intervals because not everybody has enough evidence of ADHD at the age of 7 to be diagnosed. And that should even be repeated through the adolescent years.
It seems like there are so many people that work in this field that don't see it in themselves. And that it should be a key. If you enjoy working with people with ADHD, be thinking, why do I enjoy these people so much?
Yes, although there's a host of people who don't have ADHD but love somebody with ADHD that are working in this field too.
Thank you for your time.
Thank you so much. Have a good day.
Bye.
We believe all girls with ADHD should get a fair start in life by getting diagnosed by age 8. Visit us at www.findtheadhdgirls.org. Thank you.